Medicine Grand Rounds, it's really my pleasure to introduce Dr. Ciaran Kelly, who is our visiting professor today. Dr. Kelly received his undergraduate and medical degrees at Trinity College in Dublin and undertook training in residency, internship residency and fellowship in Dublin as well, culminating in training in gastroenterology. He served as a tutor and lecturer initially at Trinity College in Dublin before he came to the United States to become an assistant professor at the Boston University School of Medicine. He was promoted to associate professor and then moved to Harvard Medical School, where he has been ever since at the BI Deaconess Hospital. He's an attending physician there. He's program director for the GI Fellowship Program and founder and medical director of the Celiac Center. Dr. Kelly has published broadly, I counted 123 original manuscripts. I make note that his first two papers were actually in pulmonary, but by paper number 3, writing about hepatitis, he hit his stride as a gastroenterologist. He's also authored 82 reviews, chapters, and editorials. He's been well-funded, currently funded as PI on an R01 and co-investigator on other federal grants, as well as funding from the BI Deaconess Medical Center Celiac Center Foundation grant and an industry grant. He's very much involved nationally with the study sections and advisory roles with the FDA, the NIH, the Wellcome Trust, the Medical Research Council of London, and the American Gastroenterology Association, where he serves as representative for the C. diff Management Guidelines Committee most recently. He serves on 5 editorial boards, currently editor-in-chief for Current Opinion in Gastroenterology, and has served in major leadership roles for the American GI Association. He is an avid teacher and lists a number of advisees and trainees, many of whom are now in academic careers of their own. He's received a number of awards over the years, including Fellowship in the Royal College of Physicians of Ireland, Fellow of the American College of GI, and the American Gastroenterology Association Fellowship. He lectures broadly, and we're very fortunate to have him come and speak with us today on the topic of Clostridium difficile beyond antibiotics. Please join me in welcoming Dr. Kelly.
Thank you. Thank you for your very, very kind introduction. It's a great pleasure indeed to be here, and I've been taken care of like royalty, which I guess if you're Irish that isn't necessarily a good thing, but in this case, in this case, it has been very positive. So it's a real pleasure to speak to you about one of my main areas of interest. Yesterday I had the opportunity to speak about my other CD disorder, which is celiac disease, and this morning I'm going to talk about C. diff. So C. diff infection, or the organism at least, was first identified in the 1930s when it was cultured from the stool of healthy neonates. In fact, up to 70% of healthy neonates will harbor C. diff for several days, at least, after they're born, because, of course, colonization resistance, which I'll be talking about later, doesn't exist in a neonate because they don't have an established microflora. And for that reason, many neonates will carry toxin-producing C. diff, and that's where it was first identified. Ironically, it was called the difficult or difficile bacterium on the basis that Hall and O'Toole had great difficulty growing it, and it took them a long time. They could see it by gram, it took them a long time to grow it, and when they eventually grew it, they called it the difficult bacterium for that reason. Unfortunately, obviously, we have the opposite problem, that we're growing it in our poor patients on a daily basis when we really absolutely do not want to. In the 1950s, the clinical phenomenon of pseudomembranous colitis, C. difficile-associated diarrhea emerged as broad-spectrum antibiotic use increased. I'm going to show you that in 1958, stool transplantation to treat C. diff was first described in patients with fulminant disease. And that was actually a full 20 years before the origin of pseudomembranous colitis in the form of toxins produced by C. diff were first described in the late 1970s. And very quickly thereafter, effective treatment with metronidazole and vancomycin was described. And really, treatment has not changed very much, almost not at all, over the ensuing years, up until very recently when another agent was approved, fidaxomicin. So let me begin by saying that everything I talk about in terms of management of C. diff is not FDA approved, with the only exceptions being vanco and fidaxomicin. They are the only two agents that are approved, and metronidazole, which is still probably the most used agent, is not FDA approved, nor are any of the other things that I'm going to talk about. Since 2000, the incidence and severity of C. diff has increased fairly dramatically, and I'll show you some data on that. So given those phenomenon, I think it's clearly time to look to new treatments. And I'm going to spend the second half of my talk talking about new approaches to C. diff. The Beyond Antibiotics title is a sort of two-way title. One, that C. diff is resistant to many antibiotics and emerges during or immediately after antibiotics, and in that way is beyond antibiotics. But also I'm going to talk about management options, interventions beyond antibiotics, since the antibiotic approach isn't really serving us very well at the moment. So I'll talk a little about changing epidemiology, a little about changes in standard therapy as regards how we use the traditional agents and the new agent fidaxomicin, and then I'll talk about new treatment options with two main areas. One, bacteriotherapy, focused on restoring colonization resistance, and the other, immunity, both passive and active immunization. So these are our rates on C. diff, death rates in the United States. And as you can see, they've been unfortunately rising quite steadily since about the year 2000. This runs up to 2006, when they had increased 3- to 4-fold over those 6 or 7 years. And unfortunately, they have pretty much continued to rise with perhaps a recent plateau, but certainly not a significant fall in death rates. And it surprised me to learn back in 2006 that at that time, reported deaths from C. diff were 4 times deaths reported from MRSA, which I would have thought of as a major nosocomial lethal infection. And if you take all your favorite GI pathogens, salmonella, shigella, norovirus, rotavirus, you name them all, you combine them all, they all together cause 1/6 the number of deaths that are attributed to C. diff. So unfortunately, it's head and shoulders above other enteric pathogens in terms of causing death, at least in the US and in Europe. The story obviously could be quite different in other parts of the world, but where we live and work, it's the main enteric, it's the main lethal enteric pathogen by far. And the CDC estimates that the increase in C. diff has been from 140,000 cases approximately per year in 2000 to a current more than 500,000 cases per year. And these are data that were published in the New England Journal earlier this year. They also estimate that there are 29,000 deaths from C. diff per annum, which is 100 deaths per million individuals. And in fact, the CDC has placed C. diff on the highest threat level of being an urgent hazard because they're so concerned about these rising numbers of cases, and particularly, of course, the increasing death rates from C. diff. So it has become quite notorious, basically. So how do you manage C. diff infection? Well, you suspect it, which is typically fairly straightforward, because most patients will have a history of antibiotic use. The next step that we all learned is to stop non-essential antibiotics. Sometimes I hope we do that. Most of the time I hope we do that, but not always. But up until very recently, it was a common sense recommendation rather than an evidence-based recommendation. But there are now data that would support the importance of avoiding other antibiotics in patients who are being treated for C. diff. These are combined data from the trial that compared fidaxomicin, which is a new anti-C. diff antibiotic, against vancomycin, which is a traditional C. diff antibiotic. And they took all of the patients in those studies, and they looked to see whether these individuals received additional antibiotics other than vanco or fidaxomicin after C. diff was being treated, during the time or after, versus those who did not receive additional antibiotics. And then they looked at various outcomes measures. And so you can see that time to resolution of diarrhea was longer in those who got additional antibiotics. The likelihood that they would fail treatment, defined as resolution of diarrhea at 10 days of therapy, was higher in those who got antibiotics. And a sustained response, which would be responding initially and not recurring, was also higher. I'm just seeing again. Every time I give this talk, I notice that these numbers are back to front, and that with antibiotics should be 25% and without 34%. So the numbers are transposed. I apologize. The point is that if you receive antibiotics, you're much more likely to not respond initially, and if you do respond, to then recur, as opposed to not receiving antibiotics. So it's evidence supporting what makes a lot of sense that you should try to avoid antibiotics when you're treating an antibiotic-induced illness. The next step is to test for C. diff. I'm not going to go into testing, but there is quite a lot happening in the realm of C. diff testing. PCR is increasingly used because of its higher sensitivity, and questions are increasingly being asked about the clinical specificity of PCR. In other words, is it testing positive in individuals who don't really have C. diff infection per se, but just have a small amount of genetic material that gives a PCR test without necessarily having proliferating toxin-producing organisms to cause disease. But that's a story for another day. Except to make one mention, and that is that we recently published a paper in a journal of Clinical Micro describing a new so-called digital ELISA, which is a highly sensitive ELISA, that's capable of measuring very, very low levels of toxin, which is the problem with the regular enzyme immunoassays. They're not sensitive enough, and also can quantify toxin A and toxin B. And so we're interested to see whether sensitive measurement and quantification of the toxins can be helpful in terms of diagnosis and prognosis, and indicating what type of management a particular patient would have. For example, somebody with very, very high levels of toxin might warrant more aggressive treatment. And empiric therapy is not recommended. It is commonplace, but it is not recommended generally. The exceptions where empiric therapy is considered reasonable is if there's a very high clinical index of suspicion, or if the patient is very severely ill, or if for some reason there's going to be a prolonged delay before you get your test result back. Most of us, I think, will get a C. diff test result back within 24 hours. And that's, reasonable time period to observe the patient, stop all the other antibiotics, observe the patient. If there's going to be a very long delay, then empiric treatment may be reasonable. But other than that, it's not recommended. It might help you to understand why. If I tell you that fewer than 10%, usually it's in the order of 8% of requests for C. diff toxin assay in hospital inpatients on antibiotics are positive. The vast majority are negative. And so if you empirically treat all the patients where you suspect C. diff, you'll be treating more than 9 patients who do not have C. diff for the 1 patient who does have C. diff. And so more antibiotics, again, being used, increasing the patient's risk for getting C. diff from the vanco. And we know from recurrence that many people get C. diff after they've completed a course of vancomycin. So it's not advocated. So how do we treat C. diff? Well, you start with metronidazole, and then if you earn vancomycin, you can have vancomycin. That was the old approach. That's not how it's done anymore. So if you still consider that metronidazole is always first line, that's not what the current guidelines and recommendations are advocating. It used to be that you would reserve vanco for those who failed or were intolerant of or couldn't take metronidazole for some reason, but that's not the case anymore. There's been a change there. The reasoning for that had been partially cost, although most hospitals will use generic vanco designed for IV use and administer it orally, and that's actually very inexpensive as a form of treatment. It's only the purpose-produced oral capsules that are expensive. The IV form is very inexpensive, and if you have a patient who's an outpatient who's paying out of pocket, it's worthwhile sending them to a compounding pharmacist to get the IV form because it can be much, much less expensive. So that was one reason. And the other was VRE, but in actual fact, studies show that patients who receive metronidazole are just as likely to be colonized by VRE as patients who receive vancomycin. And that the development of VRE isn't sort of an overnight event that occurs during a course of vanco. It's an acquisition from the environment in patients who are on antibiotics and are susceptible to being colonized by the organism. So that's old history, and we move on. So why did we move on? Well, the first set of data is summarized here, and that is changing reports of failures of therapy on metronidazole. The data here shown, vancomycin before and after 2000, response rates were very high with only about 3% failures reported in the literature. Before 2000 for metronidazole, similarly, about 3% failures in the literature, but then after 2000, more and more reports came through of treatment failure with metronidazole, and it rose the overall treatment failure rate to between 15 and 20%, which is obviously a substantial difference. And then this led, when these data were sort of first put forward, people began to ask, should we really be using metronidazole since it doesn't seem to be working as well? This is a very well-known editorial written by Dale Girding 10 years ago now, responding to those data and asking, metronidazole for Clostridium difficile associated disease, is it okay for mom? Inferring that it was perhaps a slightly substandard treatment and you might not want to treat your family members with it. He readily answers his own question over dinner and tells you that metronidazole is not okay for mum, but might be okay for your mother-in-law. That's Dale's answer, not mine, obviously. He says it with a wry smile, but one way or another, the question is there. So very recently, last year, this study was published, which actually is the biggest, most robust data set, comparing directly metronidazole to vancomycin. So the study was actually for tolevimir. Tolevimir is a putative toxin binder, and tolevimir was very unkind to its owners and makers because it did very well in phase 2 and totally miserably, badly in phase 3. After all that money had been spent to run the phase 3, the Genzyme discovered that tolevimir was a turncoat that only worked 5 years ago and didn't work anymore, and so it had to be abandoned. So, however, as part of the study, they had agreed to provide the FDA and us with comparative data between vanco and metronidazole, both compared to tolevimir. And these are the comparative data. And as you can see, the response rates to vanco in red were fairly stable across different levels of disease severity, C. diff disease severity, whereas the response rates for metronidazole deteriorated as one moved from mild to moderate to severe disease. And overall, taking all comers without any consideration of disease severity, metronidazole was significantly inferior to vancomycin, with an 8% differential in response rates. And so these are actually the strongest data that would say that vanco is a better drug that people are more likely to respond to. Just in passing, I would say that recurrence rates are almost identical between the two agents. Not quite, but almost identical. There's slight edge for metronidazole, but it's very slight. And really the big finding is this inferiority versus metronidazole. So what does that lead to? Well, it leads to these recommendations. These actually preempted the study that I just showed you. They were based on a smaller study done in Illinois with Czar as the first author that many of you will be familiar with, which also suggested the inferiority of metronidazole, particularly in severe disease. And so the current recommendation is mild to moderate disease, it's still okay to give metronidazole. However, for patients with severe disease, vanco should be used first line, not waiting for metronidazole failure, but using it up front as the first treatment. And if a patient has so-called severe complicated, and I'll show you in a moment what that might mean, then to use oral vanco, use it at high dose, 500 milligrams instead of 125 QID, and add metronidazole intravenously for severe complicated disease. I will say that these recommendations for patients with severe complicated or fulminant C. diff are not evidence-based. They are purely fear-based because we know how badly those patients do. And so we sort of agreed that despite the lack of evidence, we would give it our best shot by giving them a higher dose, which may or may not be better than the lower dose, and by adding metronidazole, which may or may not help, but nonetheless, it seemed as though that might be the right thing to do. So, what is severe disease? If you're supposed to treat it differently, how would you recognize it? What is fulminant or severe complicated? You're supposed to treat that differently again with double or dual therapy. How would you recognize it? Well, severe disease is often identified by the presence of a high white count or a rising creatinine. And those are sort of the most broadly used and identified. And most studies that have looked at this question have found that white count and creatinine are elevated in those with severe disease. And in fact, the height of the white cell count is prognostically important. As it rises, the outcomes become less and less good. And if it's over 50,000, and I'm sure many of you have seen patients with white counts greater than 50,000, and I'm sure that very few of those survived. And so as the white count rises, the prognosis becomes less and less good. The creatinine is sort of a first indicator of end organ damage caused by the systemic effects of having severe C. diff. And then some other parameters that have been used, but where the data are less strong, would include severe diarrhea, abdominal pain, fever, low albumin have also been used. For severe complicated, you're talking about conditions such as toxic megacolon, hypotension, organ failure, frank renal failure, usually the second organ, to show problems after the kidney and after hemodynamic problems are the lungs, and respiratory failure requiring ventilation is not unusual in patients with fulminant disease. And then I've listed some of the other parameters that have also been suggested to be indicative of severe disease. So we performed a study to try to determine if we could predict patients who are going to develop these severe outcomes and who might warrant aggressive treatment, either vanco or high-dose vanco plus. And so we looked at over 200 patients at our institution in Boston, and we looked at those who had severe outcomes. And by that, we define that as meaning C. diff-related ICU admission, colectomy, or death as severe outcomes. And then we looked at those and found that those outcomes were associated with a rising creatinine, a high white count, or being older. And then we went to a validation cohort, which was a combination cohort of patients from Dublin and Houston, Texas. And the scoring was simply additive. So if you had one factor, you were 1. If you had 2 factors, you were 2, etc. And you can see as the score went from 0 to 3, the likelihood of a severe outcome went from 11% in those with none of these risk factors up to 60% in those who had all 3 of the risk factors. So it's not a perfect prediction tool, but it can provide an indication. I'd say of all of these, the white count is probably the single most valuable tool in managing patients with C. diff. And if you're managing a patient with C. diff and their white count is rising, you should get nervous. Intensify their treatment and consider whether or not they might need a surgical consult. So what else can you do for patients with fulminant disease in addition to dual therapy with oral vanco and IV metronidazole? Well, a few other interventions have been reported. Tigecycline, there are case reports of using IV tigecycline. Intravenous immunoglobulin is something that we described about 20 years ago now for patients with fulminant or recurrent disease. It may or may not be helpful. There have been no trials. And finally, FMT, as I'll show you. FMT was first used in fulminant disease, although it's now mainly used to prevent recurrence. And of course, ultimately, patients may require colectomy if they're not responding to medical treatment. And colectomy is the standard operative intervention for fulminant C. diff. But a different operative intervention was described recently that I think is worth being aware of. In this study is done by Neil and colleagues in Pittsburgh. What they did was they performed a loop ileostomy instead of a subtotal colectomy, so a much smaller operation. They then used the excess of the ileostomy to wash away all the badness, which is C. diff and its toxins, using polyethylene glycol. And then they added in the goodness, which is vancomycin, using the same entry point. And then they gave repeated installations of vancomycin over the ensuing days. So they treated 42 patients in this way, most laparoscopically. 93% of the patients were able to keep their colon. And mortality rates, most important, were 19%, which of course isn't perfect, but the historical mortality rate in this scenario in their hands had been 50%, so it was substantially better. So Dr. Neil subsequently has attempted to do a control trial, comparing directly in a patient population either subtotal colectomy versus loop ileostomy. Not surprisingly, nobody's signing up for his trial. Because when you consent a patient and tell them, well, you have an option of a 50% death rate from having your colon removed compared to a 19% from keeping your colon, very few people go for option 1. Everybody goes for option 2. So basically, he's been unable to actually study it in a controlled trial because patients understand the difference between 19 and 50% death rates. So a fellow of ours who was, at the time we saw this patient, chief resident at Beth Israel, called me one afternoon and said, Ciaran, you'll want to come and see this. I've been asked to see an older woman who had a recent sigmoid colectomy, and now we're asked to see her because of increased colostomy output. She also has a fever and high white count. And bedside diagnosis of pseudomembranous colitis was made on the basis of the appearance of her colostomy, where you can see, usually you have to look inside to see this, but she had a window to the world based on her colectomy, and we're able to see it at the bedside. So Andrew was very excited by this, and I think submitted it to the New England Journal, but I can't remember if they published the image or not. So moving on then from regular and severe C. diff to recurrent C. diff, which is a second substantial problem, looking after patients with C. diff infection. And of course, the problem here is that we treat this antibiotic-induced disease with antibiotics. And by doing so, we perpetuate the dysbiosis, which is the source of the disease and susceptibility. And so it's a cycle of antibiotics causing disease, treated with antibiotics, resulting in more disease. There are several risk factors for recurrence, but the strongest is having recurred already. The overall recurrence rate, whether you're treated with metronidazole or vanco, is 25%, first time round. If you've already had one recurrence, it increases to somewhere around 35 or 40%. And if you've had 2 or more recurrences, it's over 50%. In some studies, in fact, I'm going to show you some data from patients with multiple recurrent C. diff, it rises up to 65 or 70%. And so that's the single greatest indicator of recurrence risk, is having done it before. So we've also looked at prediction of recurrence, and this may be important if you're considering using an expensive new drug like fidaxomicin to prevent recurrence, to be able to select out patients who are most likely to benefit from the extra $2,000 or whatever you're going to spend on treating them with fidaxomicin above metronidazole or generic vanco. And so the predictors of recurrence that we found were age, being sick, and using additional antibiotics, as I already mentioned. And as you can see, as you go from none of those with 0 recurrence rates to all 3 with 67% recurrence, there's a stepwise increase in risk of recurrence. So my colleague who was on this paper with me, Lorraine Kine, contacted me after the paper was published, and she'd been snooping on a C. diff blog, a patient blog about C. diff, and she was amused to read that somebody talking about a new paper came out about risks of C. diff recurrence, and they found that being old and sick and being on antibiotics put you at risk for C. diff recurrence. And the comment was, those geniuses at Harvard, I wonder how much money they spent and wasted coming to that conclusion. Which Lorraine, who's sort of into these type of things, says, well, that indicates clinical validity of the prediction tool. So it's actually a good thing that it's bloody obvious that those are indeed risk factors. So it's not a perfect tool by any means. So how do we manage recurrent C. diff? Well, the recommendations are same again for a first recurrence. Given that those patients have a 40% recurrence risk, many of us feel that that's not a very acceptable approach, that we really should try something different, something better. But the current recommendation is same again, although fidaxomicin is an option. Second, it's prolonged and tapered vanco, for which the data are very weak. There are actually better data for fidaxomicin, which I'll show you in a moment. And then the third and subsequent, there are several options, including giving vanco followed by rifaximin, and there's a study that supports that that might be helpful. And the best data are for FMT, and that's mainly been given to patients with multiple recurrences. So these are the data supporting the recommendation for a prolonged tapering or pulse dose vanco. And really it's one study. The study was not a randomized trial. It was an observational study of how patients with multiple recurrences of C. diff were treated according to their physician's choice. And when the different treatment choices were compared vis-a-vis the outcome of further recurrences, they observed that those who received a tapering dose or a pulse dose of vanco had lower recurrence rates. So it's not a controlled trial, it's an observational study, and it's the best data that's available, and because basically it was the only data available for a perhaps effective treatment, it found its way into the guideline. But we all agreed that the data were weak. So the new kid on the block is fidaxomicin, and fidaxomicin is more selective and less disruptive of the colonic microbiome than vanco or metronidazole. Initial response rates to fidaxomicin or to vanco are very, very similar. Fidaxo was marginally better, but certainly not statistically significantly better. With recurrence rate, however, there was a significant difference, with the expected 25% recurrence rate with vanco reduced to 15% with fidaxomicin. So it's not zero, but it's a significant substantial reduction by about 40% in recurrence rates. And then if you look at the sustained response, which, as I said earlier, means responding initially and not recurring, in other words, having a single treatment for your C. diff and being essentially cured of the infection, fidaxomicin did better. And it may or may not surprise you to see that of those who are treated with vanco, only 64% have a cure, an effective treatment of their infection. The rest will either not respond initially or will recur later. And so it's only really 2/3 who are responding to vanco compared to 3/4, which is still not perfect, but it's better, to fidaxo. The problem, as you all I'm sure are aware, with fidaxomicin has been persuading people to pay for it. And that's, it seems to be a good drug, but it definitely is an expensive drug, and it has been difficult to persuade people who are paying of its worth. But these are actually probably the best data on efficacy in patients with recurrence. Remember, patients with recurrent C. diff have a 35 to 40% recurrence rate. So in this study, which is part of the fidaxomicin phase 3 controlled trial, it's a subgroup analysis, looking only at those who had a previous episode of C. diff and are now being treated for a recurrence of C. diff, you can see that they do indeed have a 36% higher recurrence rate with vanco, and that this is, again, reduced substantially but not completely by fidaxomicin. And these are the best data available on treatment of a first recurrence of C. diff, showing the superiority of fidaxomicin over vancomycin for that particular patient group. So infection prevention and control we all exercise and work hard at. However, I would argue that it really isn't working because of the data that I showed you at the very beginning. More and more cases, more and more deaths. We're trying hard with infection control, but it's just not cutting it. Before I go on to options, I wanted to show you a picture of a dog. And this dog is a hospital visitation dog. And it's an illustration of this study from Journal of Hospital Infection, where they cultured hospital visitation dogs' stool and looked for pathogens. And you can see 80% of these dogs had a pathogen in their stool. And by far the most popular pathogen of hospital visitation dogs is C. diff. 58% had C. diff in their stool. So one might conclude that one should be careful handling or being around a hospital visitation dog. I conclude that it's very dangerous for hospital visitation dogs to be brought into hospital because they're licking the ground and they're picking up C. diff spores, and something should be done to protect them against the C. diff. You do actually have to be careful when you give a dog an antibiotic. They can get lethal C. diff. Certainly my vet was very particular about which antibiotics I should or should not use for my dog. So be wary. Don't bring your dog into hospital unless it needs to be in there. So I wanted to turn to the final section of my talk, which is talking about non-antibiotic approaches, or what I'm calling here nature's cure. First, restoring colonization resistance. Second, immunization. So probiotics are the obvious approach to restoring colonization resistance, but they've been very disappointing. Everybody wants them to work, but nobody can really show that they do work. They're still used. They probably won't harm anybody, but you certainly cannot rely upon them. None of the recommendations, here I'm quoting, not recommended by IDSA SHEA US recommendation, insufficient evidence to support from the European guideline, and limited evidence for use from the American College of Gastroenterology. So nobody believes that the evidence is in to support the use of probiotics either to prevent or to treat, which is unfortunate. And the reason is there aren't enough well-conducted trials, and in particular, when a trial shows a positive result, it has not been reproduced. The same agent has not been shown in a second trial, and ideally a multi-center trial, to actually be effective. This is an example of a recent multi-center trial of probiotics to prevent antibiotic-associated diarrhea on the left, and C. diff infection. These are elderly patients in hospital on antibiotics in the UK. There's over 1,400 patients per group, and you can see there's no significant protection either against antibiotic-associated diarrhea or against C. diff infection. So for the moment at least, probiotics are not considered to have demonstrated efficacy. This is the first report of treating C. diff, pseudomembranous colitis, with fecal microbial transfer, or FMT, aka stool transplant. And it was in Colorado, 4 very sick patients who responded pretty much immediately, within 24 to 48 hours, from being critically ill in the ICU from C. diff to recovery. And so very, very dramatic response. And the authors said that this simple yet rational therapeutic method should be given more extensive clinical evaluation. And so it wasn't. For about 40 years, nobody really paid much attention to it at all. For aesthetic and other reasons, it was sort of just not considered, it's not something we do. However, more recently, a controlled trial was performed, and this was the first controlled trial of FMT in Europe. And on the left are response or sustained response rates from FMT. 80 in patients with multiple recurrent C. diff, 81% had no further recurrence after a single FMT, and they received or were offered a second, those who recurred, and then 94% had no further recurrence. And this compares to basically 70 to 75% recurrence rates in those who were treated with the standard agent vancomycin. This trial is small because it was stopped. The Data Safety Monitoring Board determined that the vancomycin therapy was clearly inferior and that it was unethical to continue to study the use of vancomycin for treatment of these patients, since FMT was so clearly so much better, and so they stopped the study and moved on. Microbial diversity is high in donors, low in those with multiple recurrence, and after infusion, after transplantation, the microbial diversity increases in the patients, and so this is thought to reflect restoration of colonization resistance as the mechanism of action of the intervention. And so there's been a lot of interest. That study really sparked a lot of interest in this approach in C. diff, and people are looking at different ways of administration, different ways of obtaining the samples. And more recently, stool banks, both academic and not-for-profit and commercial, have begun to emerge to make access to the treatment easier. Because the hardest part of the treatment is identifying a donor, screening the donor, and processing the poop. People really, it's difficult or unsavory to do those parts of the procedure, whereas the actual administration by enema or at colonoscopy, people are much more comfortable with. And so the access to stool banks has been an advantage. So I Googled stool bank, and this is what came up. But hidden in the midst of the other stools, you can see there is one relevant photograph of the sort of thing you might think of if you were working in a stool bank. My favorite stool bank is called Open Biome. I'm an advisor. It's at MIT across the river from my institution. And they established themselves in 2013, so it's a very young group. It's a not-for-profit, and their goal is to make FMT accessible by providing rigorously screened donors. So they presented a paper at our DDW, National Digestive Meeting, and they presented at that study, looking at, I think it was something like 600 potential donors. By history, they excluded a large number because of a family or personal history of things like obesity, metabolic disorders, autoimmunity, psychiatric illness. All of those are now sort of avoided in donors. And so on through to actual stool testing where a surprising number tested positive for things like rotavirus. It was a common symptomless rotavirus carriage. And eventually, 5% of the pool was actually accepted as a stool donor. And they commented humorously that the acceptance rate to be a stool donor at MIT is actually lower than the acceptance rate to be a student at MIT, which is greater substantially than 5%. So I thought that was amusing. They're now charging $350, which is far less than the unit cost, and they're able to do this because they're doing it in bulk. They're getting multiple treatment units from a single donor who's screened only at the beginning and the end. They hold that donor's unit until the donor has completed their donations, and they're rescreened at the end of the donation period. And it's only when that second screen comes back negative that they release the donor's lot. So we've moved over recently to using this as a much more convenient and economically better approach for our patients. And we're using it not just for recurrent C. diff, but also are hoping to start using it for fulminant disease. The ready access to treatment units makes treatment of fulminant disease more practical. And also we're doing some research in Crohn's disease, ulcerative colitis, irritable bowel, but those are simply research studies. And so it also facilitates doing that sort of research. This is where they've been sending stool. They told me last week that they've now treated more than 7,000 patients across the US, and they're also sending grade A US stool to Europe, where the Europeans can also avail of the very high quality product that we produce. This is a neat cartoon that I got recently from a colleague, where a pill, which is containing stool, opens up, and lo and behold, there is restoration of the microflora. This is supposed to be a fecal pill. It looks like the effect might be an LSD type effect, but it's supposed to be fecal transplantation. And that's probably the next step beyond what we're currently doing. Enemas and colonoscopies is FMT via capsules. Open Biome has just announced that they have perfected their capsules and will make them available for use broadly. There had been some problems with capsules, including bacterial fermentation within the capsule, increasing the internal pressure and causing the capsule to explode, which is okay if it happens in the bottle, not so good if it happens as you're ingesting the capsule. And so that was clearly a little technical problem that needed to be overcome. So they're confident now that they have capsules that will remain intact until they're supposed to open up. Defined bacterial cultures are another important approach. Spore preparations, and in particular, this spore preparation, which is neat, which is non-toxin producing C. diff spores. And if these organisms, this is a study where non-toxinogenic C. diff is administered, in 70% of people who got it, it colonized. And in comparison to placebo, the administration of these spores markedly reduced recurrence rates. And in fact, if you look at colonization versus recurrence, only 2% of those who were colonized recurred. So it would appear that if you can successfully colonize with non-toxigenic C. diff, you will prevent toxigenic C. diff from colonizing on top, because you'll have sort of taken the niche. The second area that I'm going to quickly go through is on immunization. These are our work from some years back, where we showed, if you look at serum antibodies against toxin, individuals who are symptomless carriers have higher anti-toxin than the individuals who become colonized and get disease, suggesting the presence of natural protective immunity. And in a separate study, we showed that individuals with very high toxin levels, which are down this side of the graph, have much lower recurrence rates after C. diff compared to those with very low toxin levels who have very high recurrence rates. So again, suggesting protection from anti-toxin immune response. I already mentioned our use of IVIG for recurrent and fulminant disease, not proven, no studies, but this study does support the value of passive immunotherapy. This is a study using anti-toxin A and anti-toxin B antibodies given to patients during treatment of C. diff, so during this first 10 days when they were on treatment for an episode of C. diff. And as you can see, following that treatment, the expected 25% recurrence rate occurred in the placebo group and was reduced substantially in those who got the antibodies. So the antibodies given systemically appear to be capable of protection against the disease. And in fact, Merck has taken that project and has just reported in abstract form the results of its phase 3 study. And what the phase 3 study shows is that the anti-B antibody, bezilotoxumab, was significantly better with lower recurrence rates compared to placebo, whereas the anti-A monoclonal did not have an effect, and the combination was no better than the B alone. And that was shown, basically, the efficacy of the B alone was shown in both of their phase 2 studies. And so it's likely that that will go forward for registration. It's likely it'll be very expensive. These are monoclonal antibodies. And then finally, there's been a little work done. This is a study we did on active immunization, which is an old study now. This project has gone at the speed of molasses. It really has been so slow. This is showing immune response to vaccination here. And this project is now in phase 3 with Sanofi Pasteur. It's a toxoid vaccine. And the expectation is that the phase 3 is probably going to take several more years. I think it's a 50,000 person study. So it's a vaccine field trial. They are huge studies. And it's expected to take 3 to 5 more years until they get enough cases of C. diff to be able to say whether or not the vaccination is effective. So to finish up, the incidence and severity of C. diff is getting worse. Vanco is the first-line therapy for severe disease, not metronidazole, and I suspect that the new guidelines will probably downplay the use of metronidazole even further because of the new data that I showed you on efficacy. Vancomycin is the first new agent approved and is, for many years, is associated with reduced recurrence rates, and novel non-antibiotic approaches are being worked on to restore colonization resistance, and these are already in use. FMT and FMT by pill are both available now, and then the other approaches such as mixtures and spores are being worked on and may become available in the near future. Immunization, the HUMABs have demonstrated efficacy now in phase 3, but they've not yet been approved. And the vaccine, as I said, has a few years to go, but hopefully in 3 to 5 years, we'll have data from the vaccine, and hopefully it'll be positive. Thank you.
Thank you, Dr. Kelly. I must comment that the clock here is wrong, but we have maybe 4 minutes for a couple quick questions and quick answers, please.
Thank you for such an engaging talk. I had a question about FMT, and if you could comment on donors conferring diseases or chronic medical illnesses to the recipient. For example, I've heard of case reports with a normal weight individual receiving FMT, and then from, for example, an obese individual, and then they became obese afterwards.
Yeah, there is a report of that. A mother who received FMT from her obese daughter, and the mother became obese. And that's the reason why all of these restrictions are being added to the donors. And metabolic disorders and obesity and autoimmunity and psychiatric disease have all now become exclusions for the donors. And it will reach the point where it won't be 5% acceptance. We'll be like down at 0.2% because all of these things are continually being added for fear of transmission of a problem.
There's a question in the back, Dr. Mackey.
2 points. The first is I'm surprised you didn't really comment on encouraging the use of antibiotics that don't perpetuate C. diff. Because, for instance, with gram-negative infections, there's too often the use of drugs that have anaerobic activity, and we know, for instance, Piperacillin and Tazobactam, that will perpetuate C. diff, where you can use other drugs that will not perpetuate C. diff, and I think that that would greatly reduce the amount of C. diff. My second point is I'm surprised that we're not talking about using floral reconstitution as primary therapy from the get-go. Why are we dancing around it? It's hard for me to believe that in 10 years we're not going to be using fecal reconstitution as primary therapy for C. diff.
So I agree with your first point. I do have a slide about, what I call the good, the bad, and the ugly slide, which talks about things like fluoroquinolones, second and third generation cephalosporins as being highly likely to, across all the way to, for example, IV Gent, which essentially can't cause C. diff. And that is very important when you're choosing an antibiotic for a patient, especially a patient at high risk for C. diff. I agree also that it is logical to use fecal restoration therapy at an earlier stage, and I think the availability of pills will encourage that and make it something that people will be giving in the way they might have given a probiotic.
One last question.
You mentioned that you had sent out 7,000 samples of this stool pill from your biome. Do you have results on how many of them are actually successful in terms of numbers?
Yes, they are actually monitoring results. They have a register, and you have to sign up for the register in order to receive their product. And the data are, something around 85% success rate.
With that, we've got to close. I want to thank Dr. Kelly for an outstanding grand round.